Hi, I'm Dr. David Robertson, and this is part two of Immunology 101. As before, I'm still a partner at Allergy Immunology Associates. I have no financial conflicts of interest, and I won't be discussing off-label use of medication. The goal for this talk are to complete our discussion of basic immunology, both for basic understanding, but also to make future talk on understanding immunodeficiencies clearer. So in part one of the presentation, we looked at the innate immune system, and today in part two, we're going to look at the adaptive immune system. So the primary cells of the adaptive immune system are lymphocytes. There are three primary types: T cells, NK cells, and B cells. We're going to focus primarily on the T and B cells, but I want to talk about NK cells briefly. NK cells are peculiar in several different ways. Like T cells and B cells, they can recognize antigen presented by antigen presenting cells in MHC, or the major histocompatibility complex, but they can also function in an MHC independent way. They can, on their own, recognize antigens. So if you remember, that's being able to recognize antigens without MHC is more characteristics of some of the components of the innate immune system, like complement or toll-like receptors. So NK cells, both conceptually and functionally, share some features of the innate immune system, but also of the adaptive immune system. They can also recognize things that other cells can't. So for example, they can recognize lipids. In terms of overall function, NK cells play a major role in self-regulation, which is to say that NK cells are very important for clearing out damaged cells of our own immune system. So they're kind of always on surveillance, they're always circulating around looking for areas of trouble. And so they're kind of their own self-contained units. And to continue the military analogy, I'm not sure if anyone recognizes the guy on the left. So this is Judge Dredd from comic books. But I would say that his tagline was they're judge, jury, and executioner. So they can go around, and if they see something wrong, they actually immediately act and delete those cells from circulation if it's a damaged cell. They also play a role in fetal immunity. And I think the closest analogy from, again, the military perspective would be that they're similar to the military police. So they're always circulating and they're just kind of on surveillance. In terms of immune dysfunction, isolated defects in NK cells have been described, but they're extremely rare and well beyond, honestly, anyone at the NIH. They're more of academic interest at this point. NK cells can be affected by various forms of SCID, but that's always, as we'll talk about in a little while, in association with T cell defects and possibly also B cell defects. The last thing to note about NK cells is they do have characteristic CD markers, clusters of differentiation. So if you see labs ordered to look at lymphocyte subtypes, the CD56/16 cells are your NK cells. And I think that's really probably all that is necessary to say about NK cells at this point. So for the rest of the time, we're going to focus on T cells and B cells. These two populations of cells really do the bulk of the heavy lifting in terms of adaptive immunity, which is the side of your immune system that learns and gets better over time. So together, T cells and B cells can recognize a huge array of antigens. In theory, they could recognize up to 10 to the 27 different antigens, which is 10 quadrillion different possible protein strains. That's a really large number. Interestingly, you only have 3.2 billion base pairs of DNA in your body. So how do you go from 3.2 billion base pairs, which actually you need 3 base pairs to code for one amino acid. So how do you go from 1 billion base pairs to recognizing 10 quadrillion antigens? Well, there's several different mechanisms at play here. Some of these you probably remember from immunology and then have kind of blocked from your memory. So the first is VDJ recombination, right? So you have several segments of a V portion and then several segments of a D portion and several segments of a J portion. And each one is genetically different. And by recombining them, you get several 100,000 different possibilities, right? So on the left, you can see, you've got V1, D1, J1, and the second one, you've combined a different sequence, so you have V2, D3, J5, and so on. So the way that this process works is you get this kind of hairpin, right? So if you want to have section 7 in this example, the two sections of 7 kind of come together, and then the hairpin is sliced out or excised. And these things are called recombination excision circles. And these are what are part of SCID screening. So both T cells and B cells create recombination excision circles. All forms of SCID, which is severe combined immunodeficiency, have T cell deficits. And so the testing that is now done as part of the newborn screening in many states, including the state of Massachusetts, where we are, it's a $6 test done on the blotter paper as part of the newborn screen. Does a PCR to look for T cell recombination excision circles, which are also known as Trecs, T-R-E-C-S. And so if you don't have those, that's a sign that you may have SCID or that there's some type of problem with your T cells. And we'll talk about that more when we actually do the talk on immunodeficiencies. So the first step is recombination. And then the second step is called somatic hypermutation. And this is actually intentionally taking advantage of randomness. There are areas of your of the T cell and the B cell DNA sequence that are actually poorly conserved. They are hypervariable regions which are prone to mutation. And so the idea here is that the mutation is actually a good thing. And so this is like monkeys typing at typewriters. The advantage of this is that you can use a relatively limited repertoire of DNA to churn out a huge variety of possible receptors. And this is really where the lion's share, this is where you go from several 100,000 to 10 quadrillion antigens comes in. So it's a very clever thing. A downside of this is that in addition to being able to recognize many, many different antigens, you're also going to create B and T cells that can recognize self-antigens. And so this is actually the heart of autoimmune disease. But when these guys are maturing, when your T cells and B cells are maturing in their thymus and bone marrow respectively, if your body creates cells that recognize self, they're supposed to be deleted. So there is a safety mechanism here, and that's called negative selection. So these guys are maturing in tissue, and then before they enter circulation, they go through the high endothelial venule to leave and then kind of go out and start doing their thing. In that area, there are intentionally supposed to be expressed self-antigens along that tube that they pass through. And the gene one of the major genes that plays a role in this is called AIR, which is autoimmune regulation and expression. And if you have a problem with AIR, either it's not completely functional or it's completely absent, you get a variety of problems. So AIR plays a major role. So loss of function or hypofunctional AIR is associated with the autoimmune polyendocrinopathy syndromes. So that's worth knowing. So these are typically have thyroid dysfunction, but may also have parathyroid dysfunction or pituitary dysfunction. And if you have complete absence of AIR function, you get an immunodeficiency called APSED, which is autoimmune polyendocrinopathy, candidiasis, and ectodermal dysplasia. It's pretty bad. So this is also why a tendency to develop autoimmune diseases probably runs in families, but not necessarily everyone gets the same autoimmune disease because there is this component of randomness. So in one family, someone may have lupus, another person may have rheumatoid arthritis, another person may have Crohn's disease, but they all may be in some way related to dysfunction of AIR. Okay, so this is kind of how the B and T cells get this massive repertoire. So in the B and T cell development process, though, there's all these stages. And honestly, there's naive T cells and immature T cells and effector and activated memory. And honestly, for a long time, I had difficulty remembering them. And so we are going to use the Terminator Sarah Connor method of differentiating B and T cells. Hopefully you guys are familiar with the Terminator franchise. I think they just came out with the fifth movie with a very decrepit Arnold Schwarzenegger still playing a Terminator. And Linda Hamilton reprising her role as Sarah Connor. So this, the first step is Sarah Connor. This is an immature Sarah Connor or immature B or T cells. So this is pre the first Terminator movie. And at this point, young Sarah, unfortunately, is immature, which is to say that she has no ability to either recognize the thing that she should recognize, which in the movie is the Terminator, and she's not really equipped to deal with it. So an immature B or T cell is still actually in bone marrow, where they all come from, but they don't have any type of mature B or T cell receptor. So the next step is the naive T cell. So this is Sarah Connor at the beginning of the first Terminator movie. She's a young waitress. She has not ever heard of time travel or Terminators or killer robots from the future. But the thing about this Sarah Connor, even though she doesn't know it, she hasn't met the Terminator yet, she actually has all of the skills and personality that she's going to need to effectively fight them. So she is a naive B or T cell. So she has the equipment that she needs, but she has not been yet activated. So she hasn't come into contact with them. So she's still in this kind of naive state. This is Sarah Connor towards the end of the first Terminator movie, I believe, where she has now been activated. She's out there doing her thing. She is an effector T or B cell. So she's out fighting and doing what she needs to do. At some point, though, the threat is past. And then once the threat is past, you don't really need effector cells to be out there aggressively fighting things. And then what your immune system does is some of those cells are converted into memory cells. So this is a very intimidating Sarah Connor from, I believe, the beginning of the second Terminator movie. So she represents the memory T cell. So she has immune memory. She's been activated in the past. And if you look at her, that looks like, to stay in that state of readiness, it looks like it takes energy. And it does. It takes energy for her, and it takes energy for your immune system to maintain a repertoire of memory T cells or B cells in your lymph nodes. There is no free ride in biology. So over time, if those memory T or B cells don't get stimulated, you may lose them. They may be deleted. And this is why you need a tetanus booster every 5 to 10 years. And this is also why people may outgrow their allergies, because allergies are also caused by memory B and T cells, primarily B cells. Okay, so moving on, let's actually talk about what these guys do. So T cells, these are all CD3 positive cells. So on your flow cytometry, if you ever see somebody has run, or if you run B and T cell subsets, CD3 cells are your T cells. There are multiple kinds of T cells, but the two primary differentiating factors or groups are your cytotoxic T lymphocytes and your T helper cells. And you notice that the CD markers actually nest, right? So you all see cytotoxic T lymphocytes on the left-hand side of the screen are CD3 positive, but they're also CD8 positive. On the other side, the T helper cells are also all CD3 positive because they're still T cells, but they're the CD4 positive T cells. And these guys are what are actually targeted, unfortunately, by HIV. So the CD8 cells, the cytotoxic T lymphocytes, continuing the military analogy, are like the special forces of your immune system. So in some ways, they work in a way similar to the innate immune system. They actually go out into tissue and fight or destroy one specific thing. So each cytotoxic T lymphocyte is very good at going out and recognizing one particular thing. That's what their T cell receptor lets them see. So again, the first time you come into contact with something, they may get activated, and then on subsequent exposure to it, those memory cells reactivate. And what actually happens in your lymph nodes is that those memory cells then reproduce themselves. They clonally proliferate, and they send out copies of, in this case, the cytotoxic T lymphocytes, your T killer cells, to go out and fight the threat. And then once the threat has passed, that population should decrease, and then you should go back into that memory state, ready to respond rapidly if you should be presented with the exact same threat again. On the other side, we have T helper cells. And T helper cells, you can see that it says TH0. So that is a naive T helper cell. And so T helper cells have a lot of potential to do different things. And they really are a key part of modulating the immune responses you'll see in a second. They can modulate the cytotoxic T lymphocytes, and they can also modulate parts of the innate immune system, either directly through cytokines, which are chemical signals that they release, or by their effects on B cells. So a lot of times when we talk about T helper cell subpopulations, we talk about Th1 and Th2, and those are kind of classic. Th1 cells are involved in cellular immunity and specifically affect cytotoxic T lymphocytes. They play a vital role in fighting viral infections. And then Th2 T helper cells play a significant role. They're kind of a key signaling cell in allergic disease. And so it's common to focus on these two. But it turns out there's a lot of T helper cell populations. There's Th3, Th9, Th17, T regulatory cells, T22, and we're actually discovering more and more of them all the time. Some of them, like Th17, are named for their signaling pathway. Th17 responds to and is actually very involved in IL-17. T regulatory cells are named for their role. Th9 are named because they were the ninth one discovered. So they don't all necessarily correspond with function. But for today, for simplicity, we're just going to continue to focus on the Th1 and Th2 populations. So what is the T helper cell's role in the kind of military analogy? Well, these guys are the command center or the signaling center. So unlike cytotoxic T lymphocytes, which actually go out into the circulation and fight things, these guys primarily stay in your lymph nodes. And the way that they affect things is by sending out signals, chemical signals. So, for example, Th1 cells send out interferon gamma when you get exposed to a viral infection, which stimulates the production of cytotoxic T lymphocytes, which goes out, looks for cells that are expressing viral particles, and kills them. They also work on B cells. They make IL-6, and when B cells come into contact with IL-6, we're going to talk about B cells in a second, this causes them to produce antibodies like IgG1 and IgG3 that also play a role in fighting viral infections and other infections. Now, by contrast, Th2 cells are another communication center, right? And so one of the challenges conceptually is that you can actually have more than one signal in your body. You can have more than one T helper population that recognizes the exact same thing. And this is actually the mechanism by which immunotherapy or allergy shots actually tries to fix allergic disease. If you have an allergy to something, so let's say, for example, you're allergic to cats, what that means is that you have a population of T helper cells, Th2 cells, that have recognized cat as a bad thing, and then are sending out signals like IL-4, IL-5, IL-13 that act on B cells and cause them to class switch and make IgE, which then recognizes cat as a foreign thing, binds to mast cells. So if you go to somebody's house that has cats, you get sneezy and itchy. With allergy immunotherapy, what we're trying to do is to build up a population of T regulatory cells, which send out tolerogenic cytokines like TGF-beta, which say, no, cat dander is not a dangerous thing. You don't have to overreact to it. And so what we're actually trying to do is change the signal. We're trying to change the signal from a primarily Th2 response to a T regulatory or tolerogenic response, which is actually what you want when your body comes into contact with things that aren't dangerous. So T helper cells or CD4 positive cells really play a central role in modulating the adaptive immune response. So that's a good way to segue into B cells. So B cells in a similar way to your T helper cells, don't actually go out into circulation. They stay in your lymph nodes and they produce antibodies. And antibodies are functionally the missiles of the immune system. They go out and they stick to things and to stick to cells to either promote opsonization, which would be where they're cleared from cells, or they modulate the effect of other cells. So these are antibodies. The medical word for antibodies is immunoglobulin, and immunoglobulin is long to write out, and I don't want to do that every time I talk to a patient, and so doctors are lazy, so we abbreviate that IG. So the fundamental kind of structure of an antibody is this Y-shaped. So at the bottom end, you have the FC portion, and at the top end, you have the FAB portion. So the FC portion is the constant region, and so every antibody of a subtype that you have, for example, every IgM in your body has a constant, the constant portion is conserved. It's the same. What's different and what makes each one recognize something different is the FAB portion, which is the fraction that sticks to the antibody. So what's important to know about that is that antibodies in general are very good at seeing proteins, and the binding cleft of the FAB portion is 6 to 9 amino acids. So this is why the vast majority of vaccines recognize the protein component of whatever it is you're trying to see, because antibodies stick to proteins very, very well. They don't really stick to carbohydrates. They don't really stick to lipids. So sometimes people come into my office and they say, I think I'm allergic to sugar. You can't be allergic to sugar. Now, it can make you feel funny. Eating a bunch of carbs can make you feel tired, or certainly if you have diabetes, sure, it can affect you in different ways, but you can't be allergic to it. You can't have an immune response to it. So some bacteria, right, encapsulated organisms take advantage of this fact. So Strep pneumoniae and other encapsulated organisms basically sugarcoat themselves. They protect that lipid bilayer with a polysaccharide coating, which makes it harder for your immune system to see them. It's a pretty good survival technique for these guys. Our way around that is actually conjugated vaccines, right? So we take the polysaccharide and we bind it to a carrier protein that our body can see, and that actually makes the vaccines against these things more effective. Okay, so there are 5 different types of antibody. So there's IgM, IgG, IgA, IgE, and IgD. And all these guys modulate the immune system in different ways. So IgM, the way I explain it to patients, and the way that it's easy to remember, is it's the mother antibody. It's the first one that your body makes when it sees something new. IgM binds to complement, but it doesn't do it the most effectively. And maybe there are other functions that you want your immune system to perform when it sees something, a foreign antigen. And so we generally don't want to keep IgM because there are more efficient and better ways to do that. There's IgG, which is the main memory antibody. There are 4 subtypes. 1, 2, and 3 bind complement and are associated with actually active immunity. Interestingly, IgG4 doesn't bind complement and is associated with tolerance of different antigens, which is what you want your body to do, again, when you see something that's not dangerous. For patients, I often use a hamburger analogy. If you eat a hamburger, you want your body to be able to say, oh, beef, that is not a human protein, but it's not dangerous. We're going to tolerate that. And so then you would form a T regulatory cell population and probably a B cell repertoire that makes IgG4 that says, oh, beef is okay. But if that beef is contaminated with E. coli, you want your body to be able to see that and react to it and fight that. So IgG plays a role in both active immunity and in immune tolerance. IgA is primarily involved in mucosal immunity. It's in the sinuses and the GI tract. IgE is the antibody subclass that is associated with allergic disease. And the way that this works is you have receptors for these different things on your cells. So mast cells specifically have a high affinity IgE receptor. So mast cells, as we talked about before when we did our allergy talk, are distributed throughout your body. They're tissue bound. And so your B cells make antibodies that then stick to the IgE receptor on the mast cell. So if you come into contact with something, whether it's in your lungs, your nose, your eyes, your skin, you're going to have mast cell activation, which can cause allergic issues. What does IgD do? Honestly, nobody is sure what IgD does. It is used in research studies as a marker of B cell development. It's expressed on the surface of B cells as they mature. And then there is a periodic fever syndrome that's hyper IgD syndrome where IgD is secreted at high levels. So it does seem to have some immune function, but it's just not really well defined. And it's generally lost from B cells during development. So when it's secreted like that, it's seems to be primarily a mistake. Okay, so how do we get from IgM to the other ones? Well, this goes back to your T helper cells, right? So depending on which T helper cell population is responding to the antigen, they produce different cytokines, and that causes class switching from one to the other. So remember, the difference between one class from another is the FC portion. So what happens is, again, it's actually recombination event. You excise the portion of the genome that you don't need, which would be the IgM or whatever other subclass you don't need. So the FAB portion stays the same. So IgM that recognizes tetanus, when you class switch and the right cytokines are applied, the FAB portion stays the same, but the FC portion changes, and now you have an IgG memory B cell that can recognize these things with higher binding affinity, which you see here. Now, if you look at the different antibodies in serum, you can kind of get an idea for how important they are, what role they play. So by far, the majority of the immunoglobulin floating around your system is IgG, and that kind of makes sense. IgM really is a precursor. You don't really want to keep it. You want to be able to make new stuff so you can recognize new things, but IgM is not really a great functional antibody. IgG is the main memory antibody, the main one that does the bulk of the response to foreign antigens. Trick question. I saw this one time on a prep question, I think, and the question was, which antibody does your body make the majority of or the most of on a daily basis? And interestingly, the answer is IgA, but that is mostly in the GI tract, and so it's mostly pooped out. So in serum, it's only about 15%, and then IgE is really trace. So if you get a set of immunoglobulins, you don't even get IgE on there, and IgD just never shows up. So looking at this, if you had a problem with IgA, so for example, IgA deficiency, you probably wouldn't expect it to be as clinically relevant or significant as if you had an IgG deficiency, and that bears itself out. We'll talk about this a bit more, but IgA deficiency is the most common humoral immune deficiency. So I haven't used these terms before, but you guys know them. The humoral immune response is the antibody-mediated immune response, so that's what B cells do. And then the cellular immune response is the T cell mediated, and generally that's referring to cytotoxic T lymphocytes. So the most common humoral immune deficiency is IgA deficiency. 1 in 1,000 people have it. I may have it. I don't know. The vast majority of people are asymptomatic. If they are symptomatic, they get sinopulmonary infections like sinusitis or bronchitis. Honestly, the vast majority of people that I've seen in practice that have IgA deficiency that are symptomatic, they actually end up having allergic disease. And if I treat their allergic disease, they don't get sinusitis anymore. But there's no specific treatment for it. We'll talk about it a little bit more when we talk about immune deficiencies. So having a problem with IgG production is really clinically significant, and it can be associated with significant infections. So what about IgG subclasses? A lot of times I have people that come to me and they're sent to me because somebody checked immunoglobulin subclasses and one of them is a little bit low. For better or for worse, having a single IgG subclass that's a little bit low, again, is not generally clinically significant. There is no lower limit of IgG4, so having 0 IgG4 is not clinically relevant. Its serum levels are much lower than the others, and again, it plays primarily a role in immune tolerance. Having a low IgG4 does not mean that you don't tolerate things. Doesn't play a huge clinically significant role. There is a new class of rheumatologic diseases that are associated with having significantly elevated IgG4 levels. But I think that is probably, the IgG4 is not pathogenic. It is a biomarker that's observed in people with this problem, but it's not causing the actual disease. But for IgG1, 2, and 3, let's say you have an isolated IgG2 deficiency. First of all, is it going to be clinically relevant? Probably not. And then second, even if it is, there's not that much to do about it. So, which is again a kind of a nice segue into, let's say somebody does have an IgG deficiency. What do we do about that? Well, we can give them somebody else's IgG. And so this is where this stuff comes from. So these are people, quote, donating plasma. And so if you see this lady in the front in the orange shirt, she has a big fat IV coming out of her arm, and then it actually splits into a double lumen catheter. And each one of these things that you see the people attached to is actually a sterile centrifuge. And what they do is they draw out the blood, they centrifuge it right there on the spot in cycles, and then they actually return the red blood cells to the patient and keep the plasma. So the plasma is that straw-colored stuff that contains all of your antibodies. By doing this, by returning the red blood cells, people can actually donate plasma up to twice a week or 8 times in a month. And they are not paid for their plasma because that would be unethical. They're paid for their time to sit there in these chairs. And so there are companies that make a lot of money collecting plasma from people, and then the plasma is screened for different antibodies. Patients or donors are certainly screened for HIV and Hep C and other diseases, but they're also screened for antibodies against things like rabies. And so if a person has antibodies against rabies, their plasma is actually more valuable because it can be used to make Rabdogam. So this is where any immunoglobulin that you get that has a therapeutic value comes from. So this stuff actually here is RhoGAM. So this is Rh positive antibody that you'd give to a mother to try to prevent her from rejecting the baby. You may also notice that this is CMV negative, so it's also screened for the presence of CMV. Um, so in general, if somebody has an IgG deficiency, we can give them other people's IgG. And this is actually a numbers game, right? So if somebody had an IgG deficiency and they only got my IgG, then they could only respond to things that my immune system has seen. But since their immune system isn't responding well, and they may come into contact with things that I haven't seen, the IgG is actually pooled. And so you're getting a bunch of different people's antibodies with the idea that you're going to get a good repertoire in case you get exposed to some foreign thing that you can't react to. If I give somebody IgG replacement, there actually is no IgG1 or IgG2 or IgG3 replacement. And so there's actually no specific therapy for IgG subclass deficiency. I can only give you total IgG, not a subclass. And so in general, with very few exceptions, it's not recommended that people with an isolated subclass deficiency go on immunoglobulin replacement. So in residency, you guys have probably used IgG replacement, probably not for the treatment of immunodeficiencies. In the inpatient setting, it's most commonly used for autoimmune disease. So for example, if somebody had Kawasaki's or had ITP, you may have treated them with high dose IVIG. And that's the route that most people are familiar with, giving it IV. And the nice thing about giving it IV is it's fast, you get their levels up really quickly, but there are also some downsides. For one, you have to have IV access on a frequent basis. Historically, this has been done in an infusion center, and the reason for that is that, again, in the past, there was an association with transfusion reactions. This is a blood product, but the majority of the transfusion reactions were actually because of the way that this stuff was processed and handled. There is a low affinity IgG receptor on the surface of the mast cell. If you remember, IgA can sometimes be excreted as a dimer. IgM is excreted as a ring-shaped pentamer. IgG should be a monomer. But what happens, or what used to happen, is because of the way this stuff was processed, you'd actually get IgG clumps. And so if you remember back to our discussion about allergic disease and mast cell activation, if you have a clump of IgG with two IgG receptors that are near each other, if they come into contact with a mast cell, they can actually cause non-specific direct mast cell activation. And so people were sometimes having anaphylactoid reactions to IgG replacement. With better processing over time, that has become largely non-existent. And so there is now a movement for both patient convenience and probably spurred in some part by the insurance companies to transition patients from going from an infusion center actually to home infusion, where a nurse comes out and they actually get the IVIG in their own home, which is much more convenient. There is another route of IgG replacement, and this is something that you guys probably don't have a lot of exposure to, and it's subcutaneous immunoglobulin. So it's the same stuff, just given by a different route. And so this is the thing, the device that is commonly used at home. So you can see you have this big syringe, and on the right-hand side, there's actually a little plunger thing, and you fill the syringe up with this, and then there's this capillary tubing, and it attaches to your skin with these kind of fancy stickers. And they're actually the same stickers that are used for an insulin pump. So it has a very small needle that goes right under the surface of the skin. And for IgG replacement, usually depending on the volume, there are somewhere between 2 to 4 of these. This person on the right is doing it at home on their leather sofa in their cutoff jean shorts. And so common places would be on the legs or generally on the abdomen, and you can sit there in the comfort of your own home and do this. There are advantages and disadvantages to this. So IVIG is generally done monthly, so it's less frequent. It can be done as at an infusion center, but like I said, it's being transitioned to the home. Some people are really uncomfortable with the idea of self-administering medicines or needles, and they just don't want to, they're not comfortable playing a role in their own medical care, which is interesting. The risk of anaphylaxis I left up there, although like I said, it's getting less common over time. A bigger deal for some people is for the IVIG is that it's a large solute load. And again, this is primarily historical. Well, so historically, IVIG was suspended in a solution that either had a high sugar content or a high protein content, or sorry, high salt content. And so for people with either diabetes or with fluid issues, so specifically say renal disease or congestive heart failure, getting a large volume of fluid could be bad for them. It could tip them into congestive heart failure. It's still a relatively large protein load, so there is a recommendation that if people have a creatinine greater than 1.5, you should exercise caution with IVIG replacement and either infuse it slower or choose a different therapeutic option. So subcutaneous immunoglobulin historically has been done weekly. There are now there's actually a different form that is mixed with gel, and you can do it less frequently, every 3 to 4 weeks. It can be done at home, which is also attractive for people that want to travel. So if you're going to Florida for 2 weeks or you're going to Europe, you don't necessarily have to find an infusion center in a place where you're going, because you can just take the medicine with you. There is no risk of anaphylaxis, and it's self-administered, which again can be a plus or a minus for some people. There's another actual clinical difference between the two, and I kind of alluded to this. So in general, the IgG range that you want to be in is somewhere between 600 to 1500, depending on your age and the lab that runs it. Some labs say 700, but I think in general 600 is the lower limit, a normal, where we'd start thinking about doing IgG replacement. So let's say you have a patient that's cruising along and they're somewhere in the 300 or 400s, and you're like, no, you need to be on replacement therapy. If you do IVIG, you give them a big dose and their levels shoot way up, and then it goes down. So the half-life of IgG in serum is somewhere it's about 23 to 28 days. And so over the course of 3 to 4 weeks, you get this decline. This is actually a little inaccurate. It's not a linear decline. The ability of the IgG to stay in serum and not be cleared actually by your immune system is dependent on something called the FcRn shuttle receptor. And what this does is it actually takes your IgG and temporarily shuttles it inside cells where it hides from the immune system and being cleared out, and then it comes back out. If you overload, if you saturate the FcRn receptor, then the IgG gets cleared out more quickly. And so it's actually a nonlinear pattern. So it's actually rapid decay early on, and then it kind of settles out. So there's some concavity in real life to this graph. But I drew this graph by hand, and this is what you got. Drawing straight lines is easier than drawing curves. So over time, what you see happens is that you spend the vast majority of time in the target range. But there might be a little bit of time right at the top of an infusion when you're a little bit high. And there's a time, usually at 3 to 4 weeks where you're a little bit low. And a lot of times patients say, I feel tired, or I feel kind of crummy, or I get sick at this 3 to 4 week mark. So with subcutaneous IgG replacement, you're doing it weekly. So you're actually using 1/4 the amount. So you're getting less large shifts. So it takes a little bit longer to get back up to where you want to be, but you spend more time in the target range. And so in general, there's some data that says that people are less prone to infections with subcutaneous replacement, and they generally feel better. So I tend to favor, for in the outpatient setting, subcutaneous replacement. Again, if there are patients, every patient's different, and you got to do what's right for them. And I certainly have patients on IVIG. I have one memorable patient who, again, just doesn't want to play any role in her medical care. But she actually has COPD and congestive heart failure. And so doing IVIG started to become problematic for her, and maybe it was actually pushing her over the threshold into congestive heart failure. So we switched to subcutaneous for a while. Her husband was actually the one that was doing the replacement or administering it for her at home. Very sweet couple. And after a while, she's like, Dr. Robertson, I just can't deal with the needle pokes. I don't want to do it. I want to go back to the IVIG. So we're doing that. I'm coordinating with her cardiologist. She gets some extra Lasix on the days that she gets her infusions, and we run them extra slow. So you got to do what's right for everybody. And I think, honestly, that I believe is it. That is the adaptive immune system. So you've got your NK cells, which are like your military police, the T cells, which play a role in cellular immunity. The cytotoxic T lymphocytes and your T helper cells, which are really the communication center or linchpin for modulating the immune response. And you've got your B cells, which play a role in humoral immunity. And that is the immune system. So I hope this was useful. You can't ask me questions on the internet. So if you have them, feel free to send me an email, or we can talk about it when we talk about immunodeficiencies. Take care.